Good afternoon, everyone. Welcome to this COVID-19 session. I hope you all had a great lunch and are ready for our speakers. My co-chair today is Maurizio Cacconi, who is the president of ISICEM. He's giving another lecture, so he'll be slightly late. So you'll have to do with me for the beginning of this session. My name is Lenny Derd. I'm an intensivist at the University Medical Center in Utrecht. And it's my honor to announce the first speaker, Professor David Menon, who is based at Cambridge in the UK and who is an expert, as you all know, on neurocritical care. And David, the floor is yours.
Thank you. Thanks very much, Lenny, and thanks to the organizers for giving me the opportunity to talk about the organ that really matters. So the title of this session is wrong. This is where all the action is. So anyone who's been looking at the COVID literature, you may have seen this on Twitter. This is what the literature is like. Every day there are another 1,000 papers to contend with. So I've had to be very selective about what I'm going to talk about. And the first thing I'm going to talk about is mechanisms in pathophysiology. For pathophysiology, it's quite useful to go back to the neuropathology in the brain. And this probably is the best of the papers that has emerged. This is from Berlin, 43 patients aged 51 to 94 years. And what they show is fresh territorial ischemic lesions in 6 of the patients, widespread astrogliosis in nearly 90% of them, and microglial activation and cytotoxic T lymphocytes, particularly in the brainstem, the medulla, lower medulla, upper medulla, and the other parts of the brainstem. They also saw some meningeal cytotoxic T lymphocytes, so an acute inflammatory response. They found SARS-CoV-2 in 21, about half of the patients, predominantly in the lower cranial nerves and in the brainstem, but the presence of SARS-CoV-2 was unassociated with the severity of neuropathological changes. So it looks as though that this was, at that time, when the patients died, an innocent bystander, and something else had been happening before then. So if we think about the various things we've seen there, we've looked at an immune response, an infarction, we've looked at an inflammatory response, and also viral invasion. There are a variety of papers now that talk about pathophysiology, and this is as good as any of them. This was last year in Annals of Neurology. And what you can see is that the SARS-CoV-2 infection can affect the brain either through systemic disease causing physiological abnormalities or through autoinflammatory insults, with the so-called cytokine storm. It can cause direct invasion, but this doesn't happen often as a cause of disease. It can be due to late autoimmune, an adaptive immune-mediated response. And we mustn't forget that physical insults might also contribute to it, stretch of nerves, particularly for peripheral nerves. So those then are the pathological and the pathophysiological changes. But what about the epidemiology and clinical presentation? Now, one thing that COVID has taught us is how to work as a team. And in many parts of the globe, there have been collections of clinicians who have put together epidemiological exercises. The Global Consortium Study of Neurological Disorders, Dysfunction and COVID, GCS NeuroCovid, is driven by the Neurocritical Care Society in the US, but is a global endeavor. The European Association Academy of Neurology has put together ENERGY, which is the EN registry, and the CoroNerve collaboration in the UK has been something that I have been participating in, as well as in GCS NeuroCovid. So if we try and go one step further, what we would like to do is to bring everything together, and Tom Solomon and other colleagues in the UK had suggested a global Neuro-COVID-19 research coalition, and towards the end of this talk, I'll talk a little bit about what sort of outputs that might be producing. But that would allow us to bring together the strength of numbers in each of these individual studies and really draw some strong conclusions. But what sort of disease levels are we looking at? What are the incidents? There are a whole lot of review articles. There are probably more review articles than there are original articles now, but this is as good as any. This is from Hallie Prescott's group, published ahead of print, due to come out in annual reviews next year. And you can see that about 14% of hospitalized patients are estimated to develop encephalopathy, psychosis or mood disorders in 6%, stroke 1 to 5%, seizures less than 1%, myelopathy less than 1%, and myopathy 17%. Now, these are reasonable estimates, but these are all flawed, not just in this paper, but in many papers, because most studies have a very poor estimation of denominator. We don't know how many patients have come into the hospital in many of these instances. But they give you some idea of the relative incidence of these neurological complications and sequelae. The timing varies. I'm not sure that this is really helpful, but it can either precede, accompany, or follow systemic disease, depending on what it is. There have been a few reports of very convincing cases preceding systemic disease. Very often it accompanies systemic disease or follows it. Less commonly, we're just seeing isolated neurological presentations. And though you have the presentation with evidence of recent coronavirus infection, there's always the question about the causal link, whether this is an incidental finding in neurological disease in someone who just happens to have a SARS-CoV-2 infection. Well, to give you a slightly better idea, this is, again, a study from the Coronerve group in the UK, again with the flaw that there's no clear denominator, but telling you about the relative distribution. The second paper emerging from the group, and this is about 250 patients with either central nervous system involvement or peripheral nervous system involvement. You can break that up, and the largest single group is cerebrovascular. You have a lot of patients presenting with delirium or psychiatric disease, central inflammatory syndromes, peripheral neuropathies, and radiculopathies. And then these can then further be broken up into, in terms of the cerebrovascular incidence, into either ischemic, the small little bump here is TIA, hemorrhagic conditions, and cortical venous sinus thrombosis. And this is in the absence, obviously, of vaccine. You can see in both of these, and also down here, there's overlap between different categories, suggesting patients have multiple phenotypes. Indeed, you can go still further and start breaking this up into large vessel, small vessel, and multi-vessel involvement. But it's also important to say that rarer presentations, such as dissection, have also been reported. And with these more rare presentations, you wonder whether there is a causal link, and you can always find a pathophysiology that connects them, or whether, again, it's the incidence of two separate diseases. So I've talked to you a little bit about the epidemiology and clinical presentation, but I'm going to talk for much of my talk on COVID-19 related encephalopathy, which is gathering a lot of interest. And it's also because there are now good evidence that the brain is insulted in many patients, at least those who have severe COVID. This is a paper on biomarkers, on neurofilament light and GFAP, both very good markers of brain injury, from Gothenburg, as many good papers on biomarkers are, showing that you have elevated levels of both. And you can see that both these increase with age, but what you can see is that the distribution for patients with mild, moderate, and severe COVID increases steadily, suggesting that this is related to the severity of systemic disease. There are other papers that look at these biomarkers both in the CSF and in the plasma and are roughly similar. There isn't good evidence that these biomarker elevations are associated with actual infection. So this is because of peripherally driven either physiological insult or an autoinflammatory or autoimmune insult. In many of these patients, this is a time course from the same paper, you can see that they're quite high to start with and rapidly come down. And as far as this population was concerned, by the time they got to 3 to 4 months, levels were much lower. And we know that when these biochemical changes are associated with encephalopathy, the outcome is worse. This is a large study from a database from the US. And what you can see is that encephalopathy is associated with worse outcomes. This is an unadjusted analysis, but that's not surprising because the sicker the patients, the more likely they are to have encephalopathy. But here in a propensity-matched analysis of just over 1,000 patients, what they found was there's still a significant difference in terms of requirement for critical care services, requirement for intubation, and death, suggesting that it's independently important as a risk factor for disease course and outcome. So what can we do about it? And this is what has emerged from the Global COVID-19 Neuro Research Coalition, which I talked to you about before, led by Ben Michael from Liverpool, and something that I've been involved in as well. Very pragmatic, with involvement of people from low and middle income countries, colleagues who have really made very strong contributions, but also from the US and many European countries. And looking at primarily systemic pathophysiology and primarily CNS pathophysiology. What is the information it gives you? It suggests you should suspect a diagnosis if there's altered consciousness, cognition, personality, or behavior. A robust diagnosis requires that the patient have a diagnosis of COVID, so you need WHO COVID criteria for probable or possible disease. There needs to be a plausible temporal link between infection and symptom onset, but as I've already told you, it can precede, accompany, or succeed it, so there's a lot of flexibility there. We need to make sure that there isn't an alternative primary disease. So if someone comes in an atrial fibrillation and has a clot in their left atrium and then has a stroke, trying to attribute all of that to COVID, directly to neuro-COVID, would seem unreasonable. But you also need to think about organ dysfunction, intoxication, or primary autoimmune disease that was unrelated to the COVID. And in terms of management, it's quite important to distinguish encephalopathy that is proportionate to systemic COVID-19 severity from primary brain disease due to COVID-19. And what the paper goes through, and this is available as a preprint, it's been submitted for publication, but the preprint is available, is go through the various pathophysiological mechanisms that I've talked about, and then go through sets of investigations in terms of what you're looking for and when they're indicated, neuroimaging, both CT and MRI, and EEG, lumbar puncture, and autoantibody tests. And as you might imagine, it's pretty pleomorphic, the presentation. You can have a variety of imaging presentations. The EEG appearances can range from formal seizures to non-convulsive seizures and non-convulsive status epilepticus, as up here, or just a slowing with an encephalopathic EEG. But there's a flow chart that you can go through, and those of you who are interested, I recommend you to look at the paper, but I can summarize that here. What it suggests is that every patient who comes in should have a universal neuroassessment, if nothing else, something as simple as a GCS or a 4 score. And this is a strong recommendation based on non-randomized trial evidence that cardiorespiratory monitoring should be calibrated to the systemic disease, because hypoxia and hypotension will cause neurological injury, and we want to make sure that we can minimize it. We want good quality fever management to avoid hyperpyrexia. There are now lots of reports of neurological disease being associated with temperatures that are very high. Need to think about, detect, and treat seizures, both visualized seizures and non-convulsive seizures and non-convulsive status epilepticus. Corticosteroids and IL-6 antagonists have now got good quality randomized trial evidence for systemic COVID. And there is a feeling amongst many clinicians who are looking at this that once we started doing this, the neurological complications may have come down, but that's really medicine-based evidence rather than evidence-based medicine. You need to think about corticosteroids, intravenous immunoglobulin, or plasma exchange in patients with suspected immune disease based on clinical lab neuroimaging or new seizures, and that makes rational sense, because regardless of whether the disease is because of COVID or not, that's the way you would treat it. The question then is, if encephalopathy is not adequately explained and you're in a lower middle income country where you don't have access to some of these investigations, or the patient's too sick, should you be using corticosteroids or IVIG or Plex? Certainly, the expert opinion is if the suspicion is strong enough, it's certainly something worth thinking about, but it's a very individual choice. So what about the latter phases? And this is quite a quick thing to say. We have a whole range of pathophysiological mechanisms, the physiological insults, the cytokine storm, autoinflammatory storm, autoimmunity, prolonged critical care, the drugs we use in critical care, and psychological stressors. And all of these can contribute to late effects of intensive care for the patients that you and I treat. And when you look at the syndrome, which is now being called the post-acute sequelae of COVID-19 or long COVID, it's suspiciously similar to the consequences of severe critical illness in general, except I suppose that many of these patients don't have critical illness. And certainly trying to ameliorate some of these physiological drivers in the acute phase might be really helpful. My final bits are about trying to understand how much of this you can actually attribute to COVID. What are the caveats and cautions we need to worry about? And particularly now, much more so than early in the pandemic, assigning causality is going to be quite difficult because people are entitled to have Guillain-Barré, they're entitled to have autoimmune encephalopathy. These are conditions that we've got used to having in our neuro ICUs. But now a lot of people who are in the population will also have either serological, virological, or clinical evidence of COVID. And saying that just because they have those two diseases, they're connected, may be a very difficult thing to do. And we have to be careful and look at large epidemiological series to make sure that that's the case. And we also need to think about whether these changes are specific for COVID-19, because we know that these lesions in the brain have been described before. This is from Tarek Sasha and Jilali Anand many years ago, this is in 2014. And indeed, the pathological findings, which are also described from that group in the Lancet now 17 years ago, have been shown in patients with sepsis and in patients with COVID. So to finish, the take-home messages are this: COVID-19 is associated with a range of neurological complications and sequelae. Some of these associations may be false or simply reflect critical illness in general. However, it's very likely that others are related to the disease. These can precede, accompany, or follow systemic illness. They're pleomorphic, but a lot of recent interest is focused on COVID-19 related encephalopathy, which may be driven by physiological insults, specific pathophysiology such as autoinflammation, direct CNS infection, I suppose so, but it's not common, and drug-induced encephalopathy we need to think about, for example, steroid psychosis. Current treatment is supportive and addresses the syndrome that you see. Think about tight physiological control, metabolic homeostasis, keeping the sodium stable, nutrition, making sure they don't get thiamine depleted, management of ischemic stroke, but this is modified by systemic illness and by infection control issues. Consider and treat seizures, including non-convulsive seizures, aggressively. Consider autoinflammatory seizures. Think about corticosteroids and IL-6 antagonists, and similarly autoimmune disease as you would treat otherwise. Thank you very much.
Thank you very, very much, David, for that excellent overview, and I think also some good pointers for the public for clinical practice. Unfortunately, we do not have time for questions at this time. If we have them later in the session, I hope David will be available for questions, and if not, then after the session. So it's now my pleasure to introduce Professor Mette Berger, who is a professor of critical care at Lausanne University and is an expert in nutrition of critically ill patients. The floor is yours.
Dear Mrs. Chairperson, dear colleagues, it's my pleasure to talk to you about another black box, the gut. I mean, it's very logical to have it after the brain because, as you know, there are as many neurons in the gut as in the brain. So let's have a look at that. My disclosures. And then something. Well, when we first got this disease, there was not much experience. And this shows in a recommendation that published by a group of Chinese experts from Wuhan and focusing on the nutritional aspects of it, emphasized that there was a requirement for nutritional screening upon admission because quite many patients, because of the disease, had not been eating for quite some time before ICU admission, which was a risk in such, and for the gastrointestinal side effects that required monitoring. They required enteral nutrition route being used first, to try and go lowish the first week, to use the different options we have. This is typical of the COVID. As for the brain, we have more reviews and expert opinions than true data, but there are some. What do we know? I looked, of course, through our usual tools, and there are quite some things out there. The COVID, we know what it is caused by now. We know that the symptoms are very wide range of spectrum until the life-threatening stuff, which brings them to our ICUs, that there are enteric symptoms, nausea, vomiting, and diarrhea. But we also now know that the gastrointestinal tract is one of the target organs of this virus. Why so? Because the angiotensin converting enzyme 2, which is very much expressed in the epithelium of the alveolar cells, is very strongly expressed in the intestinal cells. And ACE2 is a main receptor for SARS-CoV-2. It's a natural receptor, and you find it really widely. And this will explain quite some of the aspects of this virus. Here you have the summary aspect of it, and up here you actually show that the spike proteins will link directly to ACE2 receptor, as you probably already know. And this will then activate the various processes which lead to virus replication, etc. And what are these aspects regarding the gut? Because ACE2 receptor doesn't have the same function as renin-angiotensin system in the gut. And this is very specific and has been very nicely investigated by a few authors, because ACE2 is involved actually in uptake of amino acids, and in particular of tryptophan, which is an essential amino acid I will tell you a little bit more about. And actually, how does it happen? Because ACE2 favors uptake of tryptophan by stabilizing the transporter of this amino acid. This will impact on the microbiota, will impact on immunity, and through the downregulation of the ACE2 by the virus, we will actually have intestinal effects. What links tryptophan to inflammation and immunity has been well described. I mean, you can find several papers on how this is done. This essential amino acid fuels actually the synthesis of some further molecules, which kynurenine, abbreviated kin afterwards, serotonin, indolin, and the kin pathway produces metabolites which are really essential to NADH, etc. This pathway actually can be blocked, and the TRP metabolism controls through these pathways the hyperinflammation and induces immune tolerance. So if you don't have tryptophan, you will have more inflammation and less immune tolerance. How does this then exert its effects? Well, there will be proliferation in the gut, and afterwards, from the damaged epithelial gut, you will actually have translocation, exacerbation of local cytokines, which will migrate and contribute to the inflammatory damage of other organs. So the gut is actually absolutely at the front line. This is a system, well, a sketch of how it is during opiosis. Actually, you have these various transporters, and you will be able to activate mTOR. These will have impact actually on what is in the lumen, and you will have a gut microbiota which is actually multiple, varied, etc. With increasing dysbiosis, the worst being observed actually in the critical illness, you will have blocking of this, and the blocking of the mTOR receptor from tryptophan deficiency will impact actually the microbiota, and you will have an invasion of more pathogenic bacteria. What is the involvement then of a severe acute disease on coronavirus infection? Well, let's go back to SARS in 2003. This was already a SARS-type virus, and already during that first epidemic, we knew that there were involvements with some patients having actually diarrhea, and the shedding of the virus was persisting very long, and the longer this shedding persisted, the more severe disease you had. And actually, there have been quite a lot of investigations done during this 2003 epidemic, which actually showed that you have virus in the mucosa of the intestine, and that it's a fantastic site for replication, explaining why it is persistent in these areas. So, sorry. What are the gastrointestinal symptoms we are faced with during our pandemic now? Well, you will see that there are hepatic alterations, that there is diarrhea, but contrary to what was told during the first period, it is not that bad. There is nausea and vomiting, but also not that bad. But probably most important, what I have started explaining to you with these ACE2 inhibition effects. And we observe depletion of opportunistic pathogens and commensals, loss of salutary species. I don't know if you have seen one of these COVID patients with black faces or blackness of the face. This is one of the intestinal manifestations. It's actually explained through endocrine changes and estrogen metabolism alterations in the liver. This occurs in the presence of liver dysfunction. It is not frequent. It's quite, well, special. And it resorbs apparently rather slowly. So let's come to the gut microbiota. We have a situation of normal gut, which will actually change to what I just told you, a predominance of pathogens. And we have a reduction of the symbiotic mix. And this will favor inflammation, will favor translocation, will favor local production of cytokines. But clinically, what do you observe? Just very briefly, some observations we have done, because we tend to consider the COVID patients as very different from the others. Actually, we have 2 consecutive cohorts we have been studying of persistent critical illness in our ICU. I mean, there is 1 week between the admission of the last non-COVID to the first COVID. And actually, we ended up comparing 52 persistent critically ill patients defined by mechanical ventilation for more than 10 days. Age, etc., was similar, but of course, we all know the mean weight of these patients is often heavier, and they tend to be having less comorbidity, as showed by the McCabe in this case, and they tend to have a lower SOFA than the usual persistent critically ill patients. You know, you get them in, you intubate, and if you have a standard operating procedure, you start feeding them enterally immediately. This is exactly what happened. What is this graph showing? 30 days, and the areas represent the proportion of days. We were studying actually 2,600 days of the patients, and you see the blue area represent enteral feeding. The dark blue area is parenteral nutrition. What you visually can see is that these patients were actually fed enterally, actually very few problems, and were fed very rapidly with, in red, very few days of parenterally. So they were easy to handle. There were a few exceptions, but not. Did they have diarrhea? Here you have the non-COVID and the COVID, the first 10 days. You see there is no difference with non-COVID patients. And from day 1 to day 30, actually they tend even to be more normal and to have less diarrhea than persistent critically ill non-COVID patients. So there are rumors about much diarrhea. If you feed them with fibers, and I'm coming to this point, you won't have problems. Why am I bringing up fibers? Because there are things you can do to enable actually balancing these microbiota. This is a study that I recommend you to go and use because the design of the study is very well done. It's not in critically ill, it's volunteers which have been exposed to omnivore or vegan diet Of course, for any one of you who knows that the vegan diet is very high on fiber and the omnivore medium, and they compared that to enteral nutrition with no fiber at all, fiberless diet. And they gave that for 6 days, and then they submitted the volunteers to a microbiota depletion intervention, meaning antibiotics in the gut and destroying what happened. And then they looked at what happened during the 10 to 15 days and saw if it recovered. Well, you see from the small drawing that probably there was not very much difference between omnivore diet and vegan diet before and after, but there seems to be happening something here. How was that? Well, very nice. This is the analysis of the count by PCR, qPCR, of the number of bacteria in the gut. This is the drop you have when you eliminate this by the procedure they did. And then you have the restoration during this phase. Well, what you easily visually can see, and it's statistically different, the restoration of the number is quite similar in omnivore and vegan, but it takes quite some more time in the fiberless enteral nutrition. If you now look at the Shannon diversity of the microbiota, omnivore diet well, they start similar, but they go up again slower than the vegan. The vegan are those who restore the fastest the diversity. But look at early fiberless enteral nutrition. They do not restore it. So this is a call for use of fibers in the diet of our patients. There are numerous data now out there, and clearly we should be using them. And to come to the conclusion, the SARS-CoV-2 spike proteins binds to ACE2 receptor. Being very rich in these receptors, the gastrointestinal tract mucosa is a major target, similar to the alveolar membrane. The changes in amino acid handling, and especially of tryptophan, which is involved in immunity, result in alterations of the microbiome, which modifies the patient's immunity and increase the release of pro-inflammatory cytokines. This is done locally, but tryptophan has systemic effects as well. And the decreased absorption of tryptophan causes hyperinflammation on itself and induces long-term immune tolerance alterations. The reduced amino acid absorption, because tryptophan is not the only one not to be absorbed normally, goes in the direction of malnutrition, because you can give it, but it goes out with the stools. So we have therapeutic options now. ACE2 is target for intervention, and you know that some studies have reported decreased mortality when you use inhibitors of it. But fiber-rich enteral diets help you maintain the microbiome of your patients, which eventually will receive antibiotics during their stay of the course of the disease. So you can do something very simple and very cheap, actually, to assist their immunity. And with that, we hope there is life after COVID, and there is some to come. So thank you for attention.
Thank you very, very much for that nice overview. Again, we'll take any questions if we have time at the end of the session.
So hello everyone, and sorry for being late, but I was simultaneously a speaker and a moderator in two different sessions. My name is Maurizio Cicconi. It's a pleasure to ask the next speaker, Marlies Osterman from London, to talk about the kidney or the pancreas? The pancreas. Sorry, Marlies, bias.
No problem. Thank you very much. It's a great honor to give a talk as part of this session, and it's always difficult to follow Professor Berger. Now, she thought she was talking about a black box. I will tell you that my box is even blacker, because there's very little known about the pancreas in COVID-19. And in the next 10 minutes, I will tell you what I was able to find. These are my disclosures, and they've not influenced this presentation. I assume that the majority of you have looked after patients with COVID in the intensive care unit. And if your experience is similar to what we saw, then you will probably agree with me that hyperglycemia was a major problem, especially in the first wave. And certainly in our experience, we were faced with a lot of patients with very high blood sugars who were much more difficult to control. And some of my colleagues talked about refractory hyperglycemia. So the question is the pancreas involved in COVID-19, or does the SARS-CoV-2 virus infect the pancreas? And does it actually cause diabetes? I will try to summarize the existing literature for you. But ultimately, as Professor Berger already outlined, it comes down to the normal pathophysiology of SARS-CoV-2 virus infection, the binding of the virus to the ACE2 receptor, and the subsequent consequences. So the stimulation of inflammation, release of cytokines, and the generation of immune thrombi. We know this happens in the lungs and in the kidneys and in the gut. Do we have evidence that it happens in the pancreas? I'll show you what we know so far. What we do know is that the pancreas is one of the organs which has ACE2 receptors. And there are quite a few of them. And this was demonstrated in one of these studies looking at organ donors. So they've got nothing to do at the moment with COVID. These were just organ donors where the pathologists looked at various tissues and they identified ACE2 receptors in different parts of the pancreas, including the microvasculature, the ductal cells, and the pancreatic islet cells. So the exocrine and the endocrine system of the pancreas clearly had ACE2 receptors. In subsequent autopsy studies performed in patients with COVID-19, the investigators could confirm that the SARS-CoV-2 virus indeed infected the pancreas. So here we have a series of 4 patients who died from COVID-19. And the authors showed different parts of the pancreas. And in red, you can see the evidence of viral presence in the pancreas. And they concluded that indeed the exocrine and the endocrine compartment of the pancreas were susceptible to SARS-CoV-2 virus infection, and that this led to an alteration of the beta cells, responsible obviously for insulin production. In a subsequent study, the authors again went further and looked at the downstream effects. Again, they used autopsy tissues of patients who had died from COVID-19. Again, confirmed the presence of viral particles in the pancreatic tissue. And they did more than that. They also looked at inflammatory cells and could clearly show that various inflammatory cells, including CD45, were present and were upregulated in patients with evidence of viral infection. And they compared this with patients who had died from sepsis and noted the CD4 count for sure, and a couple of other inflammatory markers were much higher. So they concluded that a SARS-CoV-2 infection induced local inflammation, and as they could see on histology, also cell death. In a subsequent study, which has only been available now for less than a month, the authors went another step further. Again, looked at autopsy studies, again confirmed the presence of viral antigen in pancreas and in the beta cells, but also the cells responsible for exocrine function. In this case, they measured inflammatory mediators and clearly demonstrated that various cytokines and chemokines were present and again were in much higher concentrations at local level compared to other diseases the pathologists were used to. And then they noted that some of these infected beta cells had actually changed, and they reported some transdifferentiation of beta cells following a viral infection. And when they stained the tissue for hormones, endocrine substances, they noticed that the trypsin production was increased, glucagon production or glucagon presence was increased, and there was reduced insulin secretion in these infected cells. And on the right here, I have shown the trypsin secretion, just for comparison with that of patients who died from non-COVID related illnesses. So, based on autopsy studies, we have evidence that the virus indeed infects the pancreas, it infects endocrine and exocrine cells, and it causes some inflammation and cell death. The question is, can it actually cause diabetes? And that's a very important question. I personally do not have the answer, I do not know, but this was a question addressed by Attuselli in this editorial. And in his opinion, it is too premature to conclude that the SARS-CoV-2 virus can cause diabetes. Although we saw a lot of hyperglycemia, it is also fair to say there are a lot of other confounding risk factors. And in particular now, as we give a lot of steroids, often in high doses. It is also possible, in fairness, that some of these patients who died with COVID-19, and that's the data we've got autopsy data, so we're basing our understanding on data from patients who died. It is possible that some of them had pre-existing diabetes or unrecognized diabetes. And clearly, anybody in the intensive care unit suffering from a critical illness is at risk of hyperglycemia. So at this point, I personally agree with this conclusion that it may be a little bit too premature to conclude that SARS-CoV-2 virus can cause diabetes, but at the same time, cell destruction was described in these autopsy slides. So I think we have to keep our eyes open and do more follow-up studies to explore this in more detail. Lastly, what happened to the exocrine part of the pancreas? It's a very good question because there are quite a lot of case reports in the literature describing cases of pancreatitis in patients with COVID-19. Some of us will have seen raised amylase levels or raised lipase levels. So the authors of this paper summarize the existing data in the literature, and as shown here, it's not that impressive. There are some case series and case reports, but at the same time, it appears that a proportion of patients with COVID-19 indeed has an amylase rise and a lipase rise, and some have clear evidence of pancreatitis, either clinically or on imaging. So where does this leave us? At this point, I think the box is still quite black. What I do know is hyperglycemia is common, that patients who are critically ill in the intensive care unit with COVID-19 have a high risk of ketoacidosis, but it's often multifactorial. But it is possible that a pancreatic infection contributes. We saw a large number of patients who needed very high doses of insulin, and we also experienced the risk of hypoglycemia in those who subsequently recovered because suddenly their insulin production improved again. And we saw patients who were left diabetic, but whether they had pre-existing diabetes, which hadn't been recognized, or whether the infection had caused the diabetes, at this moment in time, I'm afraid I don't know. So I'd like to finish really with this slide, which was part of a recent review in one of the Nature Review journals. And they put hyperglycemia right in the middle, acknowledging that this may be multifactorial, but it may also be contributed by viral infection. But in the belief of these authors of this paper, hyperglycemia is a major contributor to subsequent cardiovascular mortality and premature death. So in my opinion, and that's where I want to conclude, this is an area where we do urgently need to do more research. What we can say at the moment is we have histological evidence of viral infection. We have histological evidence in autopsy samples of cell inflammation, cell destruction, and chemokine release. We have evidence of the endocrine and the exocrine system being affected. And what we do not know is whether this has long-lasting effects. Thank you very much for your attention.
Thank you, Marlies, and thank you for staying on time, because that gives us time for one or two quick questions. If there is any question from the audience, please come forward with the microphone. Otherwise, I start. Thank you for a very interesting presentation. It's amazing how much we are studying in a virus that we didn't know 2 years ago. It's a slightly different question from COVID. Do you think if we look at flu or other completely different viruses and the effect, actually we may start to see, I mean, clearly not the same mechanism, but this type of involvement also in other organs? Or is there any data about either viruses that bring patients in intensive care?
It's such a good question. The honest answer is that we should look, and I haven't looked yet, but preparing this talk, which is it's quite it's a bit out of the box, black box, but preparing it clearly encouraged me to look at this in much more detail. And what you've just raised is something we need to do: look at other viruses, look at what happened, just with simple flu as well. It's just sometimes difficult to tease out whether it's the virus or whether it's the high-dose steroids or. And the other problem is clearly we are relying on autopsy specimens. So how much of the cytokine and the inflammation is due to the fact that the patients had a demise? I don't know.
And as an indirect measure, I mean, it's not a very good one probably, because we know that this glycemia, it's quite common after intensive care, and sometimes it's protracted also months after that. Do you have any data in your follow-up clinic if this is different from other patients?
No, we haven't looked at that. But we were really faced with this problem of rebound hypoglycemia. Yeah. It was a big problem for us because we gave these huge high doses of insulin, and then they survived and stepped down, and suddenly something. So whatever it is, it seems to be recoverable to some extent. And then we had episodes of hypoglycemia on a general medical ward.
Yeah.
So. Yeah, it's a very new area. We have back to the question. We have not looked at that.
I wonder if we will start to study this a bit more also in other types of sepsis in the future.
Oh yeah, I'm sure.
Thank you so much, Marlies.
It's my honor to introduce our next speaker to you. It's Professor Jan Bakker, who is in the room, yes, fortunately. Who holds a professorship at multiple universities in the Netherlands and in New York. In the Netherlands, it's Rotterdam and Delft. And he's an expert on the hemodynamics of critical care patients and also the editor-in-chief of the Journal of Critical Care. Jan, welcome to this session, and the floor is yours.
Thank you for the introduction. Yeah, COVID-19 and the heart, that's not an easy one, to be honest. There is no disclosure of a conflict of interest for this presentation. We know that other viral diseases other than corona are associated with vascular damage, as we discussed already on Tuesday. A lot of viral diseases affect the endothelium, and of course the endothelium in the myocardium is precious. And so there is knowledge that other viruses do it as well, but The SARS virus via the ACE2 receptor seems to have a significant effect on the myocardium. And we will see whether this leads to myocardial dysfunction, because that's, of course, the ultimate, let's say, problem that ends up in the ICU if you have a little bit of CPK or troponin, but there is no effect on myocardial function, then okay. But if the heart starts failing, it becomes a, let's say, clinically irrelevant problem. The impact, the effect of the SARS on the human being that it's infecting is, of course, not only the heart, but also the lung. And of course, the lung is a very, let's say, important determinant of myocardial performance, maybe not real function, but performance. Because if you suddenly increase pulmonary artery pressure, the right ventricle gets into trouble. And so the impact of the heart, if it impacts both the heart and the lungs, you could have, let's say, even more trouble. And then if it impacts the vascular system as well, and you get endothelial damage and maybe some hypotension, it could get even worse. So in potential, there could be a significant effect on the circulation. If you look at what's known in already published studies, the problem with these studies is that some are autopsy studies, some are studies that's done 3 days after admission, and so time varies, the situation of the patient. So a dead patient is, of course, the ultimate consequence of COVID. So if you look at what's been published, we know that there is acute cardiac injury. There are arrhythmias. There's sometimes an acute coronary event, although in the height of the pandemic in New York, when we increased our ICU beds with 150 for COVID only, we had only one acute coronary event. Pericarditis, myocarditis, associated all with increased mortality, and we frequently see increased troponins. Now, the studies published is basically alluding to a right ventricular problem, and the left ventricular problem is very minor. It's about maybe 10% of the patients that present with some form of left ventricular dysfunction, but the majority, if anything, you find right ventricular function, and that's up to about 40% of the patient present with some form of right ventricular distress. That's not really failure, but at least there is an effect of the infection on the function of the right ventricle. This is the ultimate, of course, consequence of COVID, the patient dying. And what they showed in this publication is right ventricular dilatation and vessel thrombi in some of the vessels. And so you could have a combination of ischemia, but the most prominent finding remains an enlarged right ventricle. And interestingly, if you look at this, and it's only 32 patients, and it's 3 days after admission, and of course we do a lot of stuff to the patient that might affect both the, have negative effect on the function or even positive. The interesting thing in this study is that the worst right ventricular function or the right ventricular strain doesn't seem to be related to oxygenation parameters. It's not like let's say, the lung problem that translates itself in hypoxemia or hypercarbia or severe hypercarbia that is let's say, significantly different between strain or no strain, but it's more the dynamics, it's the mechanics of the lung that are related to the right ventricle. And so the plateau pressure, the tidal volume, and especially, of course, the tidal volume related to compliance, because if you have low compliance, you, by definition, usually use lower tidal volume, at least I hope so. And so it's more the dynamics of the lung that seem to be related to this problem of the right ventricle. This is more of the same. In this study, more patients, 214 patients, but again, a median time of the first echo 3 days after admission. They found right ventricular systolic dysfunction, but not so much related to what you would expect. So you have a diseased lung, you have abnormal mechanics, and so probably you have right ventricular afterload, let's say marked by an increase in pulmonary artery pressure. I mean, it was there, present, but only in 35%. And so the normal things that we see in, for instance, sepsis, where we have right ventricular failure, don't seem to present them as, let's say, consistently in COVID right ventricular failure. We did a study in Sao Paulo. One of my PhD students did the study, and he found 3 other university-affiliated centers in Santiago, and they did an echo study. And these are you all know them, these young fellows and residents that are extremely keen on doing echoes, and so he found 4 friends, and they did a study. And Daniel was the lead investigator in this study. And they recruited 140 consecutive patients. So every patient coming into the ICU had an echo, and they did the echo within 24 hours. So this is, if you compare it to the other studies, an early study. Immediately as possible, as soon as possible, but at least within the first 24 hours. All patients were sedated, and they did the measurement following guidelines on how to do cardiac echo in these patients. And in prone patients, they were positioned in the swimmer position, as you can see in the picture. It was observational. They didn't do any follow-up. They did do follow-up after a year, but they didn't follow up with a specific treatment for the echo pictures or diagnosis that they made. They measured cardiac output by VTI. They measured left ventricular diastolic function and systolic function, and diastolic areas to define the degree of right ventricular enlargement. And they also looked at the right ventricular systolic function. They defined right ventricular failure as acute cor pulmonale, as a difference between the end diastolic area between right ventricle and left ventricle as more than 0.6, and if it was more than 1, it was severe. And the severe one always had paradoxical motion of the sepsis. And angiogram in these cases, in acute cor pulmonale, was done in everyone. Left ventricular overload was defined as the E accent more than 15. And as you can see, here are the graphical representations of the severe and the less severe right ventricular enlargement. 175 patients were admitted, 140 were included in the study. The age was young, 57. Normal age in Santiago ICU is over 60. ICU mortality was 24%. That's basically the mortality we had in New York as well. And the hospital mortality was 29%. So some patients died on the floor. And in the following year, so they saw all patients 1 year later, only 1 patient had died. Mechanical ventilator settings were PaO2 not that bad, PaCO2 adequate, PEEP of 10, 77% were receiving muscle relaxants, and about half of the patients were in prone position. As you can see, the labs are not very abnormal. It's a general picture of a COVID-19 in the ICU. The hemodynamics were not that abnormal. A low heart rate, an adequate mean arterial pressure, a delta PCO2 as a marker of tissue perfusion, normal in the majority, SCVO2 normal in the majority of patients, hardly any lactate. Lactate is not an indicator of severe COVID. In most cases, as you can see, the percentile, the 75th is 2.5, so only 25% had a lactate more than 2.5. And the norepinephrine dosages were low, as a median 0.05, and the 75th percentile was just 0.14. So not a lot of hemodynamic compromise in these 140 patients. Left ventricular dysfunction was hardly present. Only about 10% had a hypokinetic left ventricle. About half of the patients, and so the majority were hyperdynamic. If there was an abnormality, it was more likely to be a hyperkinetic ventricle than a hypokinetic ventricle. And diastolic dysfunction, the worst grade of diastolic dysfunction was not present in any of the patients, and grade 2 in only about 10% as well. So the left ventricle didn't seem to be, let's say, majorly affected in these first 24 hours. If you then look at the right ventricle, as you can see, dilated, almost 40% of the patients had a dilated right ventricle, and in some cases severe, only 8. And acute cor pulmonale was present in 14% of the patients. That's more than hypokinetic left ventricle. So the failure of the right ventricle was much more prominent than a failure of the left ventricle. And interestingly, in these acute cor pulmonale patients, only 12% had pulmonary embolism. And so what you would expect, if you increase the afterload with pulmonary embolism, then the right ventricle is likely to fail, just like you expect pulmonary artery hypertension. Those factors don't seem to have a major effect on this failing right ventricle. Mortality was 23% if you had abnormal echo, and of course much higher if you had acute cor pulmonale. 80% of these patients died. I won't go into all the details, but there is let's say, progression of severity when you go from normal right ventricle to only dilation to acute cor pulmonale. So these patients only had dilation, and these patients, of course, had dilation plus cor pulmonale, like paradoxical septal movement. The differences again, oxygenation are not huge, somewhat more hypercarbia, somewhat lower pH in the worst right ventricular failure. But again, it's the mechanics of the lung that seem to have much more impact on this failing ventricle than the oxygenation status. If you look at macro hemodynamics, not a huge difference between normal and right ventricular dilatation, and of course the worst had worse hemodynamics, so had more requirements for norepinephrine, a huge difference, 0.2 versus 0.05, and of course they had all the same mean arterial pressure because that was regulated with the norepinephrine. Tissue perfusion, somewhat more abnormalities the more severe the patient was, and these patients also had higher lactates than only dilatation. Now, if you then look at the mortality, and so this is the patient without right ventricular involvement. These are the patients with only dilatation, and so only dilatation already has a significant mortality. And acute cor pulmonale has a huge mortality, and as you can see, these patients die rapidly, and about 40% of these patients died in cardiac arrest, let's say, underlining the significant hemodynamic compromise in these patients. If you look at the multivariate logistic regression predicting acute cor pulmonale, it was pH, heart rate, and compliance, again, lung compliance, and predictor for mortality was, of course, cor pulmonale, the PaO2, FiO2 ratio, and the acidosis. So in conclusion, the heart is frequently involved. The right ventricle more Then the left ventricle maybe 10%, right ventricle about 40% of the patients. And acute cor pulmonale in the first 24 hours is a very bad situation, and the majority of these patients die rapidly. If you survive any of these failures, either right ventricle or left ventricle, your once-a-year survival doesn't seem to be affected. And the difference between all these studies might be, of course, confounded by the time of assessment. I think an echo on day 3 is something completely different than an echo on day 1. Thank you very much.
Thanks very much, Jan, for the excellent physiological overview. Are there any questions from the floor? Don't hesitate to step up to the microphone. I know it's easier on a Zoom call, but you can still do it. If not, then Jan, you elaborated much on the right ventricle and the left ventricle in your talk, but in the beginning you also mentioned the elevated troponin that we see in some of these patients, and I always struggle with that. You also see it postoperatively, and you see it in COVID-19 patients. So what do we do with elevated troponins in these patients, in COVID-19 patients, is my question.
I had a discussion with a family member of a patient, and she was an internal medicine specialist, and she was complaining about the troponin, and it was going up and down, and she wanted to do all this kind of stuff. And I said, I mean, it doesn't make any sense. I don't know what to do with the troponin. I mean, if it's huge, then of course you go to the cath lab. But in these small, I don't know what to do. Yeah, but I'm very concerned. I said, well, the best solution is stop measuring it. And so that's what we decided. Let's not measure troponin anymore, because if it's not incredibly high, it's a marker of something is going on in the heart, no discussion. But whether it has clinical benefit and you can do something for the patient, I don't think so.
That's very sound advice. Thank you. If no other questions, we move on to the next speaker.
Thank you, Jan, and it's a great pleasure to ask to come on stage to Professor Jean-Louis Teboul from Bicêtre in Paris. I don't think Professor Teboul needs any introduction.
Thank you very much, Maurizio. Good afternoon, everyone. So I will speak about hemodynamics, a little about the heart, but not so much because Jan Berger talk about the heart function. So my conflicts of interest are on this slide. And the first question I want to answer is hemodynamics an issue in COVID-19 critical ill patients? And for this, I want to look at this paper by Frédéric Michard and others. It was an international survey, and there were 1,000 respondents to the survey, and the survey has some questions about hemodynamics in COVID-19 patients. As you can see, respondents come from Europe, 46%, from US or North America, 18%, for South America, 26%, and less from Asia, Oceania, and Africa. And 69% of the respondents measure or monitor cardiac output in their COVID-19 patients. They do this by echocardiography for the majority, by transpulmonary thermodilation devices, by uncalibrated pulse control cardiac output monitors, by Swangen for some, and all the devices for 4% only. So the question we have to deal with is there hemodynamic instability in our patients with COVID-19? If no, of course, there is no need of any specific management and treatments, but sometimes if it is yes. And different mechanisms can be responsible for hemodynamic instability. These mechanisms can be isolated or can be combined. Esoplegia, hypovolemia, right ventricular failure, and myocardial injury. just start briefly by RV failure because it was already covered by Jan Berger. Just to say that this RV dysfunction or failure occurs in a quite high level of patients. This is a study looking at 100 consecutive patients with COVID-19, and the authors performed a systematic echocardiography within 24 hours of admission. And the presence of RV dysfunction or dilatation was present in 39% of cases. This is exactly the same number as Jan Berger showed in this international study, which is not yet published, so the same number. What could be the mechanisms of RV failure or dysfunction? Of course, it could be related to ARDS, pulmonary hypertension, and I don't want to go into details. It also could be due to mechanical ventilation-related pulmonary hypertension due to the use of ventilation and sometimes a high transpulmonary pressure, sometimes hypercapnia, which can induce some pulmonary hypertension. And of course, sometimes massive pulmonary embolism. And you know, this is a meta-analysis looking at the incidence of pulmonary embolism. It was in 2020, so after the first wave, maybe the numbers now are different because of prophylaxis with changes. And overall, when we look at all the studies, overall, around 90%, in 19% of cases, pulmonary embolisms were detected in COVID-19 ICU patients. This study is interesting because it compared the presence of pulmonary embolism in COVID-19 ICU patients with pneumonia, 107 consecutive patients, it was 21% of cases, versus 6% in a series of patients hospitalized during exactly the same period, but 1 year before, in 2019. So we can say that this disease is associated with an increased risk of pulmonary embolism. Of course, if you want to detect this, you can rely on either high CVP if you measure CVP, troponin levels, we already talked about this, and of course the best way is to use echocardiography. I don't want to insist about this. Myocardial injury is a possibility, could be due to many mechanisms. Viral myocarditis, of course, cytokine storm. You know that cytokines can impair the cardiac function, and other mechanisms, including the presence of microvascular thrombosis or injury in the myocardium. The main clinical manifestations are the presence of arrhythmias or sometimes heart failure and sometimes cardiogenic shock. And we can suspect this by ECG, cardiac biomarkers, troponin, but also BNP, of course. And the best tool again is to perform echocardiography. And this is a study I already talked about, showing also the presence of left ventricular systolic dysfunction in 10% of cases. Exactly the number shown by Jan Berger before. And sometimes the presence of left ventricular diastolic dysfunction, 16%. In all these patients were no prior chronic heart disease before, of course. Hypovolemia is a very interesting issue. If we look at the recommendations of the Surviving Sepsis campaign dedicated to COVID-19, it is said that we suggest a conservative over a liberal food strategy. I don't fully agree with this recommendation. I don't fully agree. I want to explain you why. COVID-19 is frequently associated with ARDS, at least in our ICUs, of course, and the presence of endothelial cell damage, which results in VQ mismatch and lung capillary leakage. And lung capillary leakage itself can result in VQ mismatch, of course. And this can induce severe hypoxemia. At the same time, very frequently, you have coagulopathy with a high risk of thrombosis, local thrombosis, and sometimes in the peripheral vessels. And this can worsen hypoxemia, of course. But hypovolemia also could be present, at least due to dehydration, high fever, fluid losses in some cases, and reduced water intake in the previous days before admission. But in addition to this, there is a picture of sepsis with a cytokine storm resulting in capillary leakage in the tissues with absolute hypovolemia, increased venous capacitance, resulting in relative hypovolemia. And this can result in low blood flow in some cases, and finally in multiple organ failure. But also low blood flow can aggravate the risk of thrombosis, resulting also in some tissues in multiple organ failure. But also we have to remember physiology. Low blood flow can be responsible for a low PVO2. And in presence of high shunt, high intrapulmonary shunt, if you have a low PV2, you can worsen hypoxemia. What about the effects of fluids? Of course, you can aggravate hypoxemia due to the lung capillary leakage. This is a high risk of fluid administration, and this can result in severe hypoxemia. But at the same time, you can prevent low blood flow, you can prevent multiple organ failure, and the low PVO2 effect and the increased risk of thrombosis. So there is a balance between the deleterious effects or beneficial effects. And this is what we have to assess at the bedside, this balance. And we can predict the benefits, the numerator of the balance, by looking at the degree of fluid responsiveness as a risk by some markers of worsening of lung edema. In terms of benefit of the degree of fluid responsiveness, I want to go fast because, as you know now, the international societies recommend to use dynamic indices over static variables to predict fluid responsiveness when applicable. We have two categories of indices: heart-lung interaction indices, doable in patients who receive mechanical ventilation, which is always or almost always the case in COVID-19 ICU patients, or passive using test. And we have different categories of indices for heart-lung interaction indices. The most popular are pulse pressure variation, stroke volume variation. You know, when you have a high pulse pressure variation during mechanical ventilation, you can predict that the patient the heart of the patient is fluid responsive, and the patient can respond to fluid positively if you decide to give fluid. If you have a low PPV, you probably this condition is associated with unresponsiveness, fluid unresponsiveness, and of course you should refrain to give fluid to this patient. In the past, we showed that with Micha and others, we showed that PPV was far better than cardiac filling pressures to predict fluid responsiveness in septic shock patients, but we have many limitations to use it at the bedside. And one of the main limitations is low tidal volume ventilation. And COVID-19 ARDS patients are ventilated with a low tidal volume, as you know. And this is why, in this situation, we can use a tidal volume challenge, which consists in increasing the tidal volume from 6 to 8 ml per kilogram for 1 minute. And with Sheila Mayatra from India, we showed that PPV measured at 6 cannot well predict fluid responsiveness in this kind of patients. But when we increase tidal volume, we measure PPV, and now it is a better predictor of fluid responsiveness. But what was far better was a change in PPV from 6 to 8, and we found a cutoff value of 3.5%. So if PPV increases by more than, I would say, 4%, patient will respond to fluid administration. If PPV increases by less than 3%, you can say that the patient will not respond to fluid administration. And it is very, very helpful, believe me, in the case of COVID-19 ARDS patient. You don't need the presence of any cardiac output monitor for doing this, only another line. And in ARDS patients with COVID-19, as you know, we ventilate this patient with a low tidal volume, and this patient in general receive a high sedation. So this is a perfect condition to use PPV and to change in PPV during tidal volume challenge. Hand expiratory oxygen test also is very useful in this kind of patients. You know, this consists in interrupting the ventilator for 15 seconds at the end of expiration, and this can increase transient venous return and preload, and you can identify full responders by patient who increase their cardiac output during the test. And this is a meta-analysis we did with Francesco Cavelli and Xavier Monet, where we pull all the studies that address the issue of full responsiveness using hand expiratory oxygen test. As you can observe, this works very well if you look at the area under the rocker for all the studies, and we found a cutoff value of 5%. And this works very well in patients with ARDS, and better, far better than pulse pressure variation alone. Peripheral is another option, of course. It works very well. If we look at this meta-analysis, almost 1,000 patients were included. The changes in cardiac output were predicted for responsiveness when they were measured during this passive grazing test. And this works very well, as we showed with Xavier Monet in patients with ARDS, and better than pulse pressure variation alone. And of course, we have to assess the degree of full responsiveness. And if we go back to this international survey, you can see that in 84% of the respondents, maybe they are more motivated because they responded to the survey, but 84% assess full responsiveness in COVID-19 patients with echo, with pulse pressure variation, PLR, SVV, and others. So it's not so bad, it's not so negligible. But we also have to assess the risk of lung edema or worsening of lung edema in this kind of patient with ARDS. And with the ISICEM and the cardiovascular section of the ISICEM with Maurizio Cecconi and others, we said that in case of shock plus ARDS, we need to have some advanced hemodynamic monitoring technologies like AISE, transpermeate hemodilution systems, or PA catheter, especially in case of right ventricular failure. And the advantage of transpermeate hemodilution system is to provide the value of extravascular lung water, which is a quantitative measure of lung edema. And I want to show you this recent study we performed with Dr. Ruishi and Xavier Monet and others in our unit, where we measured extravascular lung water in ARDS patients with COVID-19. And we look at the values of extravascular lung water for the lowest PF ratio during the stay of the patient, and we subdivided in 5 categories in function of the value: high lung water, higher than 25, between 20 and 25, etc. And we subdivide our population of 60 patients in severe ARDS, moderate ARDS, or mild ARDS, according to the Berlin definition. But as you can observe, there is a great heterogeneity of lung water values. For example, in some patients with severe or moderate ARDS, we found some very high value of lung water. And of course, in this particular condition, fluid infusion is very risky, even in the presence of shock, even in the presence of pleural responsiveness. But sometimes in severe ARDS or moderate ARDS, we found some moderately high values of extravascular lung water. And in case of shock plus pleural responsiveness, maybe fluid infusion can be attempted. So it is very important to take into account this kind of parameter to guide your fluid resuscitation. And believe me, because I'm an intensivist, I'm a clinician, I look at all my patients, and sometimes we have very big surprises in terms of hypovolemia, in terms of fluid responsiveness, and when we give fluid to patients, hypoxemia can improve due to the PVU2 effect. So it is very important to assess this. And of course, which kind of fluids, crystalloids, balanced crystalloids are recommended as recommended. A few words about vasoplegia. The use of high sedative drugs can generate some vasoplegia, of course, and sometimes associated septic shock. And for example, secondary bacterial infection, if used corticosteroids or anti-interleukin 6 treatment, maybe sometimes you can have some nosocomial infection with associated septic shock, and it's important to use vasopressors in this situation. In particular, if you measure a low diaphragmatic pressure, which is a marker of vascular tone, in this condition you have to consider vasopressors, and sometimes even before giving fluids to counteract the effects of sedative drugs. And in this survey, international survey, you can see that vasopressors were used very frequently in 30% of cases and frequently in 27% of cases, so not so negligible. So my conclusion, we have to personalize our assessment, our decision in terms of hemodynamics, even in ARDS COVID-19 patients, and the decision of fluid infusion should be considered in cases of hemodynamic instability with organ failures, of course, and benefits with responsiveness tests higher than the risk. Lung tolerance indices can assess this. And for the decision of giving norepinephrine, we should give norepinephrine in case of low diastolic pressure, even at the early phase. And the MAP target should be individualized, of course, and increased in the case of prior hypertension, which is very frequent in COVID-19 ARDS patients. You can use vasopressin as a second-line agent. But don't forget to exclude massive pulmonary embolism of myocarditis as potential causes of shock, and there is a major place of echocardiography. Thank you very much for your attention.
Thank you very much, Jean-Louis. We have time for a very quick question, if there is one from the audience. I just would like you to comment. In my practice, I found that often the norepinephrine requirements, there's a question there, I'll come back to you in a second. Often the vasopressor requirements were probably related more to sedation that was very high in this patient. I find to use extraordinarily high levels of sedation, which is something that maybe we can also discuss. But shock and, for instance, hyperlactatemia was almost non-existent in my practice, apart from patients that develop maybe septic shock from secondary infection. So yeah. What's your view on that?
I have the same experience. I can distinguish the first wave of COVID-19 and the other waves. First wave, we did not use steroids, for example, or in very few number of patients. And we had less nosocomial infection, less secondary bacterial infection than the second wave and the third wave. So now we have a lot of patients who develop septic shock, not initially, but in second phase. And we had the surprise, is what I said, because we assess fluid responsiveness systematically, as you know, to observe a high number of patients with a high degree of responsiveness. Sometimes it is logical to try to give fluids to these patients, but of course we look at lung water, etc., to make the decision according to the balance between the benefits and the risk.
We have a question from the audience.
Thank you very much for the nice presentation. Well, we heard that there is pulmonary embolism or thrombosis higher in the COVID ARDS, and extravascular lung water and permeability index is higher in COVID ARDS. Do you think that pulmonary embolism or thrombosis are changing the values of extravascular lung water or permeability index compared to normal non-COVID ARDS?
Thank you for your question. I understand your question. I have not the correct answer for this question. In my opinion, no, but there is no data to confirm this. This is a possibility, but in my opinion, no. The presence of pulmonary embolism. Note that the presence of pulmonary embolisms now is less frequent than for the first wave, maybe because we changed also our practice in terms of anticoagulants. But to really answer your question, I don't know. I don't know if the interpretation, this is what you say, of lung water is modified by the presence of pulmonary embolism. Normally not, but not sure 100%.
Thank you.
Thank you, Jean-Louis.
Thank you very much.
And thank you also for that excellent question from the floor. It's time to introduce the last speaker who will speak about the kidney in COVID-19. And it's Dr. Osterman again from London. so we will not introduce her again, but we will thank her for doing 2 presentations in this excellent session. Marlies.
Thank you, Lenny. It's a great honor to give this presentation on behalf of Professor Ravi Mehta, who can't be here today. So in the next 10 minutes, I'm hopefully going to convince you that the kidney is also a target and a victim of COVID-19. These are my disclosures, and again, they have not influenced this presentation. Now, the kidney is really one of the organs with a very high density of ACE2 receptors. And in fact, when you look at the renal anatomy, these receptors are in many different places, in particular in the tubular cells, in the peritubular blood vessels, also around the glomeruli, and on podocytes. And podocytes are these cells which keep the glomerular capillaries in place. So all these different parts of the kidney, which obviously unique functions, have ACE2 receptors. So it should come as absolutely no surprise that we see viral particles and viral presence in the kidney tissue. Here we have the first autopsy report clearly showing viral inclusion bodies in different parts of the renal tissue. Following on from this first autopsy report, we had more reports, again, investigators reporting their autopsy findings. And again, they described lots of different things, including clotting, including microvascular thrombosis, and intravascular and interstitial inflammation, combined with electron microscopic evidence of viral inclusion bodies. So it appears very clearly that the kidney is a target. And when you look at this in more detail and actually do perform urine microscopy, urine dipsticks, then it's clear that up to 85% of patients have an abnormal urine dipstick, suggesting some insult tubular injury in the form of proteinuria or glycosuria. If you also look at the rest of the dipstick, then you'll see that 2 out of 3 will have microscopic hematuria, again, as feature of glomerular involvement. Not all of them develop AKI as defined by creatinine rise, but certainly, depending on the literature, up to 60% of patients have been reported as having AKI. So it's very common. On renal biopsies performed in humans alive, again, different types of pathologies have been described. In fairness, not many people have had biopsies, but some have had, and they have been described. And there's quite a large range, but they involve pathologies affecting the glomeruli, pathologies affecting the tubules or the interstitium. None of this is really surprising, given that the ACE2 receptor sits in various different places. So the kidneys are a common target. AKI is very common, but it would be absolutely wrong to assume that it is all down to viral infection. Yes, viral infection may play a role, we're not even 100% sure, but it may contribute to acute kidney injury, but there are many other factors which contribute to acute kidney injury. For sure, we have the downstream effects. I showed you some intravascular microthrombi on one of these histology slides, and certainly this can happen in patients suffering from COVID-19. There is general inflammation, there are cytokines, and we know that the tubules are always at the receiving end of cytokines, so kidneys suffer in the presence of inflammation. And then there are so many other things which upset the kidneys, and they have nothing to do with COVID-19. There is hemodynamic instability, there is the use of nephrotoxic drugs, there is a secondary infection and the use of aminoglycosides, and there is maybe some cardiovascular instability. So overall, in COVID-19, AKI is a multifactorial problem with many players and different players contributing in different patients. The epidemiology is also very variable, and we sadly experienced this in the UK when we were absolutely not prepared for the large number of patients with AKI. We were assured at the time by reports, the initial reports suggesting that AKI would not be a problem. And suddenly we were overwhelmed, like many other places in the world. And in the UK, as you may have heard, we even reached renal replacement therapy capacity. So the epidemiology is variable, and the question is, why is this? Well, it could be that the patients are just different, and we see different patients in some parts of the world compared to others. It is possible that our general management was different, certainly in the beginning when none of us really knew what we were doing, because it was a completely new disease. And so it may be that some of us contributed to the development of AKI. But it is also clear that genetic differences play a role. And if you look at the ACE2 receptor, then we've already known for a long time that there are some genetic polymorphisms. And this is known from all the work in ACE2 ACE inhibitors. Now, with regards to COVID, and now looking at the kidneys again, if you look at the ACE2 receptors in the kidney, and you compare different genetic groups, then we already know, as shown here, there are differences between people from Asia and people from Western countries. And it is possible that, again, these genetic differences contribute to some of the differences in reports and in the epidemiology. So, very variable and a very multifactorial problem. But what do you do about this? A couple of experts got together last year because at the time some of us were facing major capacity problems, and we wanted to know what others did and what we actually should recommend. And we started off acknowledging that there were different factors contributing to AKI. There may be the direct viral effect, so there may be direct viral invasion and infection with microthrombi. There was also obviously all the element of the indirect effects of being ill with COVID-19, so hypovolemia, hemodynamic instability, superinfection, and so forth. And then we had to acknowledge that there may also be iatrogenic effects, that the fact people used nephrotoxins, that they ventilated patients with very high pressures, which we now know is also harmful to kidneys. And so having acknowledged this, we went back to the literature, which was very sparse at the time. It's a very new disease. And at that time, and I put it to you, it's still true, there is no specific treatment for COVID-associated acute kidney injury. It hasn't changed. This statement is still true. At the time, and still, there is no role for any antivirals or anticoagulants. You would have thought if this was viral infection, then maybe some of the antivirals worked and prevented AKI. So far, we've not seen this. So with regards to management, at this time, we can only say patients at risk of AKI or with confirmed AKI should be managed according to the existing recommendations for anybody else with AKI. What we should point out is that fluid management is particularly important, and patients at risk of AKI with COVID-19 don't like to be dry, but they don't like to be wet either, so euvolemia is the aim. And with regards to any general advice, there's nothing different here. If nephrotoxins can be avoided, they should be avoided, but there's nothing special here. So the advice for managing patients with COVID-19 at the moment is very the same as anybody else who's critically ill with and at risk of AKI. However, it is possible that we, in the next few months, years or so, find new drugs, and certainly drugs are being investigated. Lastly, and then I come to the end, what happens to these poor patients? So certainly in the UK, we had a large number of patients with AKI. And my concern was, and the majority recovered. The majority came off renal replacement therapy as long as they survived, and the majority recovered kidney function. And in some patients, and quite a significant proportion of patients, they left hospital with a lower creatinine than they'd come in with. And you could congratulate yourself and think, isn't this fantastic? But you could also get very worried because this was obviously clearly a feature of muscle wasting, and the creatinine was no longer a reliable renal marker. And Perry Wilson from the US shared this concern and looked at the outcome. He was the first to look at renal outcome after COVID AKI. He focused on hospitalized patients, so it's not just ICU patients, and compared patients who'd been in hospital with AKI in the context of COVID with patients who had AKI for non-COVID reasons. And at 90 days, when he looked at the creatinine and calculated the eGFR, he noted that the patients who had had COVID had a much steeper fall in their GFR. So they were rapidly approaching chronic kidney disease. Now, these were hospitalized patients. We looked briefly at our cohort and looked at the outcome of patients who had AKI in the first wave, so that's early last year. And as I already mentioned, we were completely unprepared and overwhelmed. So in the first wave in our hospital, 76% of patients had a form of AKI. With regards to the long-term outcomes, which worried us, given that a lot left hospital with a very low creatinine, we noted that at the bottom here, at 90 days, 16%, so 1 in 6, clearly met the criteria for CKD, for chronic kidney disease. And these are people now slipping into the en route to end-stage renal failure. So this is something which very much worries me, and I think needs much more attention, because we are generating patients who in a few years' time will all be in the dialysis unit. So, in conclusion, I hope I've convinced you and confirmed what you probably knew, that acute kidney injury is common. I hope I've convinced you that it's multifactorial and viral infection may play a role, but antivirals haven't worked in preventing it. We have no specific treatment at the moment, but drugs are being investigated. And the long-term effect of this particular patient group is uncertain, but in my opinion, worrying. And with that, I'd like to thank you for your attention.
Thank you very much, Marlies. We do have time for questions, and I can see that Mette and David are both also in this session still. So if there's anybody in the room who would want to ask a question to either one of these three speakers or the other speakers, don't hesitate to go to the microphone. While we wait for that to happen, Marlies, I hope I'm not putting you on the spot, because you've told us a lot about the kidney and COVID-19, but you started with the high level of ACE expression in the kidney, and one of the therapies that people immediately think about is ACE inhibitors, for instance, or ARBs, or other drugs affecting that system. Can you reflect on what you think is the current state of that?
So the current state is that we have no data to suggest that ACE inhibitors should either be, so at the moment, patients with COVID-19 at risk of AKI should be treated as anybody else. So you stop the ACE inhibitor and you restart it as soon as it's safe. However, the REMAP-CAP trial obviously will include ACE inhibitors very soon, and hopefully we will then get some data. But specifically with regards to the kidney, there is no advice different from what the general recommendations are. It's a very good question.
I don't know the answer, but it's interesting that you tend to stop them if the kidneys are failing, but maybe that's not a good idea. Nobody knows.
Yeah. So people feel they have to. It would be quite brave to give somebody who is just slipping into AKI and ACE inhibitor on top. I suspect the only answer will come from a proper randomized controlled trial.
Are there any other questions from the floor? Yes, very welcome.
Yes, good congratulations for your excellent talk. I would like to ask you, in the case of septic shock during COVID-19, did you avoid aminoglycoside
Good question. So we treated patients with, or that would also be my advice, I would treat patients with AKI exactly as I would treat a septic patient without COVID-19. If I can avoid an aminoglycoside, I would. But if the aminoglycoside is the only antibiotic, which is, and it's most highly recommended to get the sepsis under control, I would use it.
Because some studies told that aminoglycoside could increase the risk of AKI in sepsis and favor in AKI. But what is your opinion about this?
Yeah. Undoubtedly it will, there's no question. But if that's the best antibiotic and there is no alternative, then that's what I would use to get the sepsis under control. So the advice is to avoid nephrotoxins if possible. If there is an equally effective alternative, I would go for that. But if gentamicin or aminoglycoside is the best, then that's what I would use. And with therapeutic drug monitoring for the shortest duration as possible.
Marlies, thank you very much. And with this, I would like to thank Lenny Derde for co-chairing this session and every speaker for a very interesting, very entertaining session. Thank you all.